For this discussion, we'll start first with Jaroslaw, Waligo and Kate Bushby. And we have adopted at the EURORDIS, the EU Committee of Experts on Rare Diseases, a recommendation on our shared vision across the stakeholders, the patients, the academia, the industry, and all member states. It was adopted unanimously, if I'm correct, the vision on European Reference Network for Rare Diseases. At the same time, the directive on cross-border healthcare, patients' right to cross-border healthcare, has been adopted, providing the legal instrument. And there is a committee which works in order to develop the practical guidance on that. So now we're in the phase of implementation, and this is what we will focus on in the discussion here. And first I turn to Jaroslaw Waligo, which we call by the name of Jarek. Jarek is Mr. Rare Disease at the Commission, in case you don't know. He was working with Tony Montserrat for several years. He's a pediatrician, and he's now the policy officer in charge of rare disease in the unit of the program management and diseases at DG SANCO. And I know I'm asking him the hard question, but it's not to take him personally on that, because we know how supportive he is. I would even like to avoid asking him that kind of question, because we know how caring he is. But we need to put you as representative of Commission on the spot on what's the real life chances that 10 years from now we will have this 20 or 30 European reference network that we have in the recommendation that Hank William was mentioning, and covering progressively all rare diseases to provide adequate funding and support.
Thank you very much, Jan, for this introduction. We have to have in mind that these projects were completely different from what we are going to have in the future. These projects were really projects as we know them from different programs in research and in public health. But what we are now trying to build is to actually have European reference networks to be part of the healthcare systems of the member states, and these European reference networks will be composed of the centers which are based in the member states, and on the European level they will be connected into the network and to collaborate together to provide high quality healthcare. We have to keep in mind as well that these European reference networks are not only designed for patients with rare diseases. They are designed as a general tool to bring together expertise in the areas where there is need for this compensation of the expertise. And so altogether, we have to start that discussion now, how we will build them. We are now just at the beginning of the implementation process, as you said. Commission is finalizing to set up this legal framework, and new 2 delegated and implementing acts will be hopefully adopted very soon, and these 2 documents will actually set up criteria for both centers and networks, and will as well explain how the system will be organized in order to appoint centers and networks on European level. But this is not only question, is it possible to have these 20, 30 European reference networks, to have them in place in 10 years' time, but I think the even more important question is how to organize them and what kind of care they are going to provide for patients. So what kind of tools we should use to build them in order to have this care really to be high quality care for patients with rare diseases. This is of course related to very difficult question of funding. And as many of you know, in the directive, legislator doesn't provide any source of funding for European reference networks. These networks have different roles. They are, of course, primary role is to provide healthcare for patients, But there are many other roles like research, creation of best practices, guidelines, training, and many others, like registries, for example. So this funding will obviously come from different sources, and will, when it is about research, it might come from the research programs, both from member states and from European level. When it's about training, it will come, of course, from the funding possibilities, mainly on national level for training of professionals. But what is important as well is to find possibility to fund networking process, because there are many activities which were listed in the recommendation of USERT, which we mentioned, and which should actually be financed on the European level. Unfortunately, I have to say that health program, which is our tool for financing public health initiatives on European level, has not increased since the last budgetary period, and we have the same amount of money with more tasks to cover, and tools which we have in the healthcare program are not very well suited to provide sustainable funding for the organizations and projects like European reference networks. Therefore, we have to be innovative, and the Commission is really willing to support European reference networks as well from the health program. Today I cannot say more about resources which will be available in the program, because program is in the last stage of the adoption just now in the European Parliament. So we will learn in a few days most probably what is the content and detailed content of that program. But I can say that the intention of the Commission is to finance at least some of those European reference networks. But we have to be innovative, as I said, and one of the sources as well which we should take into account are mentioned before structural funds. And we recently had a discussion with the newly created expert group on rare diseases on that, and I think that there is growing interest of the representatives of the member states to learn more about that and to see what are the possibilities at the member states level to finance at least part of the activities of the European reference networks from structural funds. And I think this is the work for all of us to try to combine those existing funding and to create a high quality European reference networks in near future. I want to as well, because you said that we need 20 to 30 European reference networks, and it is indeed one of the recommendations made by USERT. But I think that we still need deeper discussion on that topic. Of course, it should be. It is obviously not possible to have European reference network for each disease, but we need to group them somehow, and the most logical seems to be that on therapeutic areas. But we just started that discussion, and I think we need to involve all the stakeholders, starting from patients, professionals, member states, and to have more clearer vision about that, and to be ready with that very soon, because the process of implementation will hopefully start soon, and we need to be prepared for that. And last but not least, I would like to say as well that other initiatives are as well important to support that process, and we cannot actually forget about them. So it's we are talking today about European reference networks, but in order to provide high quality care for patients, we need, first of all, to have that care available. Then we need to have proper information for professionals and patients where to find that healthcare. And finally, it has to be accessible, which was mentioned in the previous session. So altogether, I think that European Reference Network will be pivotal for all those aspects which are important for provisions of the. Still remember and continue support for those initiatives like information databases, helplines, codification on rare diseases, because they are all interlinked and they are all important for that. Thank you very much.
Thank you, Jarek. And again, I know that you're in a very difficult position because you're presenting something which I'm sure you're not fully happy with, but from our perspective, and you've been kind enough to say that in working more finely on the priorities, the patients will need to be involved, and we're ready for that, and we know exactly how we see this European Reference Network to be shaped and to start with. But I see a huge gap between saying that European Reference Network are going to be pivotal for Europe, are going to be high quality European Reference Network, and no money. And here, and even with structural funds, which are very difficult to access and to frame in order to make them happening. I think we are really in front of a major challenge, which is an issue of consistency, not of the Commission officers working in the DG SANCO, but of the policymakers, of the Council and the European Parliament, and in providing the proper budget, but also overall, if I may, from the DG SANCO in making its own priorities with the limited resources they have. Because I see that as a strange situation that after 10 years of discussion of high-level group and commission expert group and etc., and funding 10 pilots of European Reference Network, there is less money to implement a directive than there was in the period before. So now I'd like to turn to our next two panelists who are, I would say, our clients of the European Reference Network, potential leaders. First, Kate Bushby, who is also on the working together with us, with Jarek and all colleagues in the Commission expert group, is in your view, Kate, in where we are today, basically, both the policy aspect but also the funding aspect, what will be the key elements to translate that vision on European Reference Network into reality?
Thank you, Jan, and thank you, Jarek. And what I'm going to say, as Jan already said, is not personal to you. We have the consensus from the EURORDIS, a multi-stakeholder group, including patients, including academics, and many of us have been involved in running and trying to sustain networks in rare disease areas now for many years, and we all appreciate the value of networking. And so this really, these documents and this vision reflects lots of hard work. It reflects experience and expertise from across the globe, really, not only across Europe. And I think that the first thing that has to happen for ERNs to become a reality is that we need to keep this on the expert group agenda. And as Jan mentioned, we need to really make it clear that being told that there are innovative ways to look for funding is all very well. We all look for innovative ways to look for funding. We write 40, 50-page grant applications, 350-page grant applications, and so forth, and we're not scared to do that. But you said yourself that the ERNs are a move from unsustainable project funding into embedding this principle into healthcare pathways for rare disease patients. And that means it's a responsibility of some higher body than us to try and scrabble around to look for funding, in my opinion. And I think that unless we have clarity on the route forward, clarity on the application process, clarity on the issues of prioritization and funding, we are going to lose headway because we have put in place so many of these structures already on an informal basis that we will lose goodwill, we'll lose the impetus that we already have. And I think it's really important to point out to those of you who aren't so familiar with the principle of the ERNs, is that the ERNs can actually help with all of the issues and problems that we heard iterated in the last sessions. They can help with diagnosis, they can help with pointing people to the right place for care, they can help with ensuring that patients have access to the management as it is believed to be correct now, and they can also be the repository for the data collection processes, which will help us to understand the effectiveness of real-life use of new medicines for orphan products. So this isn't an issue of us needing ERNs at some point in the future on some uncertain funding structure. This is an issue that we've been working towards for many years to get ERNs properly embedded in healthcare, and I think it's extremely disappointing to hear that we're not going to have that coming forward as fast as we'd wanted to. On a more positive note, I mean, we can continue to work on the principles of centres of expertise. This is a process which has been really coming up through the national planning process. It's the work that we've been doing through the joint action and the Europlan process show that there's great traction here, and that centres of expertise are beginning to have the vision of belonging to a European reference network as an incentive for them to be getting going. And we want to increase the multidisciplinarity of these centres of expertise and cross-talk to the social services and so forth, as you already heard from Dorica. I already mentioned the disease registries, and you said about the JRC and how this can be a great move forward for us to try and harmonise our many rare disease registries which we have in Europe and work on their interoperability. And again, I'd like to emphasise that this is the core tool that we'll have not only to better understand natural history, but also in the future to study the effectiveness of drugs. And Jeff, I don't know if you remember me visiting you in your big building when you worked at Genzyme to talk about this many years ago, but we can do this. The disease registries that exist are a platform that are very important for us to maintain, and the ERNs give it that context. So we're ready. We just need more clarity on the way forward, and the discussions that we've been taking over the last few years, because we've been waiting for the framework, for the directive and so forth. It will be extremely disappointing, as I say, if we reach a point where we've gone through all of this discussion process and that isn't showing us a clear way forward. Sorry.
Yes, please, Jarek.
About clarity, I think we just regarding the process, criteria, and everything like that, we will have that clarity very soon. Mm-hmm. And I don't see any danger in that, of course. Mm-hmm. We just have to understand that there is a whole legislative process for that, and we have to wait for these criteria, and they will be defined, and there will be I don't have any doubts about it. So. Well, what I wanted to say is that Jan asked me about funding of the European reference networks, and here, of course, I would prefer to say to you that we have a good solution for that. But it's not only as well about defining priorities in our program, because you have to understand as well that our program is really very limited. In comparison to the research program which was presented before, it's really tiny program, and we all have to understand that. So, and within that program, we have to actually compete between those priorities, and of course, rare disease is one of those, but we have others. We have infectious diseases, we have cancer, we have obesity, and the others, and we have to meet all those needs within this tiny little program. So it is very difficult, and I have to be frank with you that, of course, we are doing our best to well, these projects, which were pilot projects, and all these processes which we put in place in order to build that fundaments for the European reference network, it was funded from this program, but still it is not enough to fund all the needs in all the policies in health in Europe, and this we have to understand.
No, you're very much right, Jarek. Is that one of the lessons that without a much stronger drive of society and patient advocates and industry and all concerned parties to increase the budget of the health program of the European Union. We know that the treaties don't support that very much. We know that it comes very far in the priorities. But we also know that this is what citizens want from Europe, and they see the value. So maybe we have 5 years ahead of us, in addition to being creative, because I'm sure that, as always, we will all work together well and be creative to find ways to support the beginning of these European funds networks and try to find the money where it is, like structural funds and others. But that in addition, we will probably need to communicate much more about what are the positive outcomes of this health program of the Commission and of the European Union, and what will be the benefit of increasing it for the next period. And Parliament is and Commission and obviously not Commission but Council and Parliament are two of the critical places. Now I'd like to turn to our next panelist, Dominique Farge-Bancel, who is somehow more new to our field, and at least not to the field of rare disease, because she dedicated her life to some rare diseases somehow, but new to that kind of conversation. And that was the point of inviting Dominique today, and thank you, Professor, for accepting to join us. Dominique is Professor of Internal Medicine and Vascular Diseases at INSERM, but what is more interesting for the purpose of a discussion is the huge work that she has done with other colleagues in Europe in putting together a network.
I have 3 major final probably answers to your initial question. Number 1, there is no money, but we can create money. And that's what we have to do with you together. Because money is not the issue, money is there, we have to find it. And I have not heard anything about cost effectiveness. And this will be one of my conclusions. The second thing, I have heard nothing about, very few, about quality of life. And I think this is important to generate, especially if, like all of us, we are concerned as patients or doctors with our patients. And the number 3, which is probably as professor of internal medicine and involved in academy for 20 years, is how to put doctors together. How can we create the good link at the European level so as to foster the excellence? So I'll be very brief. I have 5 minutes, I know. I think with my 3 heads, the one, we started the story 20 years ago based on transnational medicine and on strange evidence in our patient that we could cure them using stem cell transplantation for a severe or rare form of autoimmune disease or autoinflammatory disease. That was the number 1. The number 2, I have that little privilege of being French, which is quite an experience, but we had, due to EURORDIS and the Orphan Rare Disease Plan, the first plan, and it took us 15 years to be recognized 8 days ago as in the second plan, French plan of orphan rare disease, the reference center for stem cell therapy in autoimmune disease. So that means in France, where you here were able to innovate on this orphan rare disease, it takes 15 years to convince people that when you have evidence-based results, and we have generated them for 15 years in clinical practice, it takes 15 years to be recognized. So I hope that if we turn out to the European level, it won't take us 15 years to achieve these European networks of excellence in a dedicated approach, which could be innovative therapy using a new, completely new approach, which has been demonstrated that the origin of autoimmune disease is not in periphery, but is in the stem cell, so in the bone marrow. And that using bone marrow stem cell therapy, whatever it is, bone marrow or peripheral stem cell or stem cell therapy alone, is a real new innovative therapy, which will be the 21st century approach. So with that in mind, what kind of answers can we put together? I think the number one, we have to have a very more clear view of what is existing in Europe. We as practitioners are dealing with a single model, a single therapeutic approach, stem cell therapy, but we are dealing with rare disease from various original disease. We're dealing with scleroderma, with diabetes, with lupus, with multiple sclerosis. So this is very delicate because we need to invent new tools, and I guess the web-based database and information and networking will enable us to have more visibility in that field, to know with whom we can deal. Because we have started that story within the European Bone Marrow Transplant Association, which was created in 1975 and which now has encompassed 300,000 stem cell transplant over 35 years. And in this European infrastructure, we created 15 years ago a specific working group on autoimmune disease, and that's where the story came from. But in 15 years, what have we been doing? We've been dealing with our European colleagues in the field of rare disease for scleroderma, European Leagues of Rheumatism, in the field of digestive, European colitis organization, in the field of neurology, and in EUROLUPUS. So it starts to be a very complex model, and the only way one individual patient, a European patient, can get through this huge labyrinth, I don't know how you would say, distorted roads would go through, is to have good information. And I think Orphanet and EURORDIS could be a magnificent platform just to enlarge the visibility of this new innovative therapy. But then we have to work with web-based experts and to follow the European Commission branch who is supporting this approach to have more visibility. This is number one. And that will enable us probably to answer to your first important point, that expertise should travel rather than patients themselves. The number two, the large data registry have been built in this field of innovative therapy, and they are existing, they are being exploited, and that can be delivered largely. The problem is we can exchange data, we can exchange biological database and samples, but how are we going to get the funds for that? Because with this approach, at least in the past 15 years, we have not been testing a new drugs. We have been testing a new model, a new concept. We're just using stem cell transplantation, which have been adopted, and we are not selling the products. So that's why the partnership between academy and industry has been so delicate in that field. And that's where the responsibility of the European funders is huge. And if we make a parallelism with what the NIH has been doing and the FDA, it's very important to see that in America, this field has not emerged at all. So my neighbor was saying that we are 3-4 years ahead towards the American, and we lose the advance if we don't get strong support at the European level to keep this advance, because we have been very innovative. We have achieved a new proof of concept. We have dissected the way bone marrow can be used, and mesenchymal stem cell now can be produced, and there are many ongoing phase 1-2 trials throughout Europe, a few at least, and the phase 3 will emerge, and this is a rising market for the industry, but in 10 years from now. So we have to have experts like you who are able at the European level to support these actions. Unless, what will happen? China has been producing in 2 years more transplant than Europe in 10 years. And China has got back 10,000 researchers from America, has created a whole valley in Nanjing just to do what Europe will not be able to do. So I think my 5 minutes are over and I have to conclude. So I think what we could keep in mind is the excellence is there, but it is scattered at each national level, and it has been brought up by either men or women or history or geography, but these networks of excellence are existing at the national level. They cannot grow up at the national level because each European country is in crisis. There is no equality throughout all the European countries. We are transplanting today our first Polish transplant. It took us a year to get the insurance, the way to come, etc. So we need to facilitate access for patients, and we don't need so many centers in Europe. Probably a minimum of 50 would be enough to develop that. Then we need to raise the awareness for adequate industry, academy, and patient association partnership, so as to ensure with the three members and the European infrastructure the capacity to invent and to go further in the demonstration of the cost effectiveness, the benefit for patients of stem cell therapy. And then we reach the second step, which is the first step was to prove the efficiency of the approach. The second one is to be more refined and to delineate better before the Chinese, because they are doing it in lupus. We are done in lupus in Europe because we had the funding, we had the agreement, but we had the no-go. We had the agreement from the patient, but we had the no-go from the administration. Fear of innovating and extra cost. So this kind of approach, which is to conclude stem cell therapy in autoimmune disease and in autoinflammatory disease, represent a 10 to 20% growing market for those of you who are interested in marketing. I'm not, I know nothing about that, but there are experts. We need academy and Europe to support us and to have good way not only of incentive, but of evaluation. And for us, evaluation are results, are registry, they are existing, publication of results, cost effectiveness, and certification. The JASI accreditation, which has been set up for 30 years in stem cell transplant, should be implemented in the field of stem cell therapy for autoimmune disease and rare disease. And therefore, we could be cost effective.
Last week with Flaminia, we were in a meeting at the European Parliament with 3 MEPs and the Commissioner for Health, Tony Borg. And Tony Borg, based on the reality that Jarek just described, said, European Reference Network, it's great, it's a label, and you should be proud when you have that label. So my question to you is, Kate, if, let's say you get the label of being the coordinator of the European network for neuromuscular diseases with 30 expert centers in Europe, you're frustrated, but are you already happy and you say, okay, that's already something, it's a leverage to catalyze other sources, or not?
Well, you've known me for quite a long time, Jan, and so have you, Jarek, and you know that I complain bitterly when things don't turn out as I think they should turn out, but then we just get on with the situation as it exists, because in the end, sitting back and fighting or sitting back and complaining for too long just wastes more time and more patients suffer in the long run. So, you know, we will do what it takes to make ERNs a reality for rare disease patients, because we firmly believe, and we have actually demonstrated, as Dominique pointed out, demonstrated through our existing networks, that this is the best way to motivate the field, to raise standards, to improve efficacy, to deliver trials, and hopefully in the end to be able to deliver new therapies. So we'll get on with whatever we need. But I would just emphasize that our experience in networking over the years is that you need a little bit of money. We call it the glue money. If you don't have the glue money, then the people in the poorer countries or the poorer centres can't attend the training courses, they can't raise their standards, they can't attend the meetings, they can't contribute to the network tools and resources as you'd want them to, and therefore the poor get poorer, and inequality is helped by being in a network, but it's not helped as much as it could be. And I'd also like to say that the possibility of badging existing networks is going to be, is I think, seen as a bit of a quick fix. And, you know, we can just badge some networks that are already out there and doing a nice job. But that doesn't answer the question for the people who don't already have networks, the very rare diseases and the people who don't yet have a diagnosis, which was a key principle in what we wrote for the Centres of Expertise
Absolutely.
and ERNs.
Yeah, absolutely. In fact, I have the same question to Dominique. With your 15 centres across Europe, you already answered to that partly, but with your 15 centres across Europe, if you are recognized as being the European network for blah, 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 then are you already happy to be the blah, blah, blah and to leverage the blah, blah, blah to make it more real? Is it already a step to reduce your fear of 15 years ahead to be recognized? Because you will be recognized.
I like the idea of the glue money. I like it, really. To answer to your question, I started saying it took me 15 years in France to be recognized 8 days ago. So I think if we can be recognized rapidly at the European level based on the existing European networks, it is already a number one. Because with that in your pocket, you can go and see the potential people who can support you as long as you develop smart tools to demonstrate you generate money. And I would just like to point out that, remember, organ transplantation, kidney transplantation took 25 years to raise up, and it cost 1/3 compared to hemodialysis. So the key question is to raise cost-effectiveness studies at the European level and to understand why we push therapy X rather than therapy Y, and how much have we invested in the past 20 years in the biologics, and we're still investing, and why is it so delicate to get support from Europe when you're not generating any new drugs, just saving funds. Because if you make the cost effectiveness in these diseases I'm dealing with, we save 1/3 of the cost.
Thanks.
So it's very interesting to try to convince the agency with that approach in mind that they can support and they will generate saving.
Thank you, Dominique. Kate, you want to follow?
And innovation.
Just one more point, that if the money is going to be limited, which we now know it is, well, we never thought it wasn't going to be limited, but if the money is going to be very limited, then glue money is important for the individual networks. But investment in the transversal structures, which would help across networks, would be a real saving and a real efficiency, because then you're not duplicating the need for registries, you're not duplicating the need for expertise or e-health solutions. You can utilise them across the board, and I know that that's a call in the Horizon 2020 this time round, which I think is good.
This is really where the study design and all of that comes. I'd like to turn for the two final comments to Jarek. If you have one key take-home message to give us to improve access to quality of care for the next 10 years, before you become the DG of the DG SANCO.
No. Actually, it is related to what Kate said. That we need to build the tools for those ERNs, which will be common tools for all of them. So we have to actually take care of that when we discuss registries, we use actually we at least try to use tools which are interoperable. When we discuss information, we use one big database which is providing information, and we support all that one database which is providing information. And the same for IT communication tools, the same for other aspects of ERNs, because we need not only to create one ERN, but we need to ensure that they are talking to each other as well, because I'm sure that we will have a lot of patients which will require care from different ERNs and which have to actually switch from one to another at some point of their therapy or diagnostic. So we have to really build a network. And one general point, I think, we without actually more integration in the other policies, it will be difficult to change as well what is happening in the health policy. So we have to understand that, and it's related to funding for the program. It's related to all activities we have in that field. and we have to keep that in mind. And that European project is really important, and it's important as a whole.
Will it be a fair summary of what you said to say that in order to address the issue of lack of funding in European Funds Network, we'll try to find where to find the glue, and the prioritization and all that, but that there is two levels to work on: the transversal infrastructure, which can be servicing this European Funds Network, and second, the integration with the national policy in the member states, with the national plan, right? So that we articulate these two elements together in order to support European Funds Network. Thank you. I'd like to give the last words in this panel to Hank Willem before we have the concluding remarks. Hank.
Okay, it was a bit of a complex discussion, and I can only view it from a more patient's view. I think there is a complex discussion about European reference networks and funding of it, and sometimes I see in daily hospital life real simple issues. The simple issue of being not with a child with a rare disease. In the Netherlands, I can go to every hospital. And I think that's so strange and not cost effective. Because all hospitals maybe think they can treat my child, but that's not true. And I especially need maybe one center of expertise in Europe, or maybe one in the world. That's what really is cost effective. So I will give you the challenge to innovate and try to find it in cost effective ways, or maybe give industry a business model. That's sometimes the case when you have to find others to fund it. Give them a business model. That's my patient's view on it.
Thank you. Thank you very much. And I with that to thanks for 4 panelists. Thank you very much.